Subcommittee will come to order, and good afternoon to everyone. I have called this emergency hearing today during recess to address a grave and serious health threat which has in recent weeks gripped the mass media and heightened public fears of an epidemic, the Ebola virus. What we hope to gain from today's hearing is a realistic understanding of what we're up against while avoiding sensationalism. Ebola is a severe, often fatal disease that first emerged or was discovered in 1976 and has killed 90% of its victims in some past outbreaks. Since March of this year, there have been more than 1,700 cases of Ebola, including more than 900 fatalities in Guinea, Liberia, Sierra Leone, and Nigeria. This time, the average fatality rate in this outbreak is estimated at 55%, ranging from 74% in Guinea to 42% in Sierra Leone. The disparity in mortality rates are partially linked to the capacity of governments to treat and contain the disease and perhaps per capita health spending by affected governments. There is also concern that given modern air travel and the latency time of the disease, the virus will jump borders and threaten lives elsewhere in Africa and even here in the United States. In my own state of New Jersey, at Centra State Hospital in Freehold, just a few hundred yards from my district office, precautions were taken. A person who had traveled from West Africa began manifesting symptoms, including a high fever. He was put in isolation. Thankfully, it was not Ebola, and the patient has been released. New Jersey Health Commissioner Mary O'Dowd reiterated to me yesterday that New Jersey hospitals have infection control programs in which they train and are ready to deal with potentially infectious patients that come through their doors. She also told me that physicians and hospital workers follow very specific protocols prescribed by the CDC on how to protect themselves as well as other patients and how to observe a patient if they have any concerns, which includes protocols like managing a patient in isolation so that they are not around others who are not appropriately protected. The Commissioner also underscored that the federal government has U.S. quarantine stations throughout the country to limit introduction of any disease that might come into the United States at ports of entry like New Jersey's, I should say, Newark Liberty International Airport. I also hope our distinguished witnesses today will confirm whether sufficient resources are available and are being properly deployed to assist victims and contain the Ebola disease. Are there gaps in law and policy that Congress needs to address? To the government witnesses especially, my pledge to you is that if legislation is needed, I will work, and I know I'll be joined by colleagues on both sides of the aisle, will work with you to write those new policies. As you know, key symptoms of Ebola include fever, weakness, head, joint, muscle, throat, and stomach ache, and then vomiting and diarrhea, rashes and bleeding. These symptoms are also seen in other diseases besides Ebola, which make an accurate diagnosis early on uncertain. Earlier today, I had a full briefing, a lengthy briefing, with the Deputy Chief of Staff of the President of Guinea, President Condé, Ibrahim Khalil Kaba, who said that the virus has masked many other diseases, including loss of fever. So many of the doctors, especially those who have never seen Ebola in this part of the world before, it's been in other parts of Africa, but not in West Africa, just simply didn't think this would be Ebola. Many of them have died. Ebola punches holes in blood vessels by breaking down the vessel walls, causing massive bleeding and shock. The virus spreads quickly before most people's bodies can fight the infection, effectively breaking down the development of antibodies. As a result, there is massive bleeding within 7 to 10 days after infection that too often results in the death of the affected person. Fruit bats are suspected of being a primary transmitter of Ebola to humans in West Africa. The virus is transmitted to humans through close contact with the blood, secretions, organs, or other bodily fluids of infected animals. Some health workers, such as the heroic American missionary aid workers, Dr. Kent Brantley and nursing assistant Nancy Wright-Bowl, had contracted the disease despite taking every precaution while helping Ebola patients. Both of them are now being treated at Emory Hospital in Atlanta, Georgia, in an isolation unit after being flown to the U.S. in a specially equipped air ambulance. While there is no known cure for Ebola, both Dr. Brantley and Ms. Wrightball have been given doses of an experimental antiviral drug cocktail called ZMapp, developed by a San Diego company called MAP Biopharmaceutical. They are reportedly both feeling stronger after receiving the drug, but it is considered too early to tell whether the drug itself caused improvement in their conditions. MAP Biopharmaceutical has been working with the National Institutes of Health and the Defense Threat Reduction Agency, an arm of the military responsible for counting weapons of mass destruction, to develop an Ebola treatment for several years. The drug, which attaches to the virus cells, much like antibodies their compromised immune systems would have produced, has never been tested on humans before Dr. Brantley and Ms. Wrightball, who gave their consent to be the first human trials. There will be hope, great hope, if ZMapp works and the two Americans who bravely agreed to test it and it has a positive effect. Still, it won't mean that it will be produced in great quantities quickly and sent to affected people in West Africa. It is still an experimental drug. Those who use it might be given complete information on its use, again, but that still is something that our experts, I hope, will address. There's also promising research being done by Tecmera Pharmaceuticals. They have come up with a drug, a process, and one of the comments that has been made that it's never been tested on humans, that it has been 100% provided 100% protection from an otherwise lethal dose of Zaire Ebola virus, but again, not in humans. It's been done in others, non-human. Unfortunately, there are other issues that impact the ability of the international community to assist the affected governments in meeting this grave health challenge. Some of the leading doctors in their countries have died treating Ebola victims. The non-governmental medical personnel who are there say they are besieged, not only because they are among the only medical personnel treating this exponentially spreading disease, but also because they are under suspicion by some people in these countries who are familiar with this disease and unfamiliar, and they fear that doctors who treat the disease may have brought it with them. Of course, it's not true, but again, myths do abound. The current West African outbreak, as we all know, and as Dr. Frieden has said, is unprecedented. Many people are not cooperating with efforts to contain the disease. There's an information gap. Despite the efforts through cell phones and radio to get the message out, of course, there is still a learning curve. As we consider what to do to meet this health challenge, I do suggest we reconsider the funding levels for pandemic preparedness. And this message is to us in Congress and to the executive branch. In the restricted budget environment in which our government operates, funding to meet these pandemics has fallen from $201 million in fiscal year 2010 to an estimated $72 million in 2014. The proposed budget for fiscal year 2015 is $50 million, and we mustn't shortchange vital efforts to save the lives of people in these developing countries. Dr. Tom Frieden, one of today's expert witnesses, has tried to assure the American public that our government is doing what we can do to address the Ebola crisis. He has announced the dispatch of at least 50, perhaps more, public health experts to the region within the next 30 days. USAID, WHO, the World Bank, the British Development Agency, African Development Bank, and many others have also are joining in trying to meet this crisis. To those who say we have no plan, I would say that planning is definitely underway, and it's being done so very aggressively. Still, there is much more that needs to be done. I would just say, finally, I've introduced legislation that's known as the End Neglected Tropical Disease Act, which establishes the policy of the U.S. to support a broad range of implementation and research and development activities to achieve cost-effective and sustainable treatment, control, and where possible, elimination of neglected tropical diseases. Ebola is not on WHO's list of the top 17 neglected tropical diseases, but it does fit the definition of an infection caused by pathogens that disproportionately impact individuals living in extreme poverty, especially in developing countries. Ebola had been thought to be limited to isolated areas where it could be contained. We now know that's no longer true. We need to take seriously the effort to devise more effective means of addressing this and all neglected tropical diseases.